to decision, navigating the lung cancer diagnostic pathway. This presentation is presented and made possible with support and partnership from Guardant. Before we begin, we wanted to mention a couple of navigation reminders. For the best viewing experience, we recommend using a wired internet connection and closing any programs or browser sessions running in the background that could cause any issues. All attendee microphones have been muted and the camera feature is disabled. You will not be able to utilize the chat feature during this presentation, but you may submit any questions for the presenters in the Q&A box at the top of your screen. We will try to address as many as we can before the end of today's program. To submit a Q&A box, again, click on that Q&A icon at the top of the screen and then type your question into the box. If you are tuning in from another device and don't see the Q&A icon, please click on the three dots and scroll to where it says Q&A. Additionally, if you have any technical difficulties during this webinar, you can also submit those through the Q&A box and we will do our best to address them. This webinar is being recorded and will be available on demand after today's session. My name is Nicole Mannion and I am the Director of Nationwide Lung Cancer Education at the American Lung Association, and I will be doing the dual role of presenting and moderating throughout today's presentation. I am joined today by two amazing guests, Dr. Mark A. Socinski, who is a board-certified fellowship-trained medical oncologist specializing in all thoracic malignancies, including non-small cell lung cancer, small cell lung cancer, and mesothelioma. He is an internationally recognized expert in the development of novel chemotherapy agents and treatment strategies for advanced non-small cell lung cancer and small cell lung cancer. He is also the executive medical director of the Advent Cancer Institute in Orlando, Florida, and a member of the Institute's Thoracic Oncology program. I would also like to introduce our second speaker today, patient advocate Michael Hu, a resilient lung cancer survivor since March of 2022. Michael is an enthusiastic advocate for lung cancer awareness and research. He enthusiastically participates in lung cancer advocacy whenever the opportunity arises, leveraging his personal journey and professional expertise to support patients and promote research for improved therapies and outcomes. As a dedicated member of All Positive Inc., Michael passionately contributes to the community. Thank you both so much for joining us today and for sharing more on your roles and experiences with lung cancer. To learn more about these roles and expertises, please see our registration webpage for this event, which you should have access to via our reminder emails. Both of these speakers have no disclosures or conflicts of interest. Here's our agenda for today. We will start with a lung association and lung cancer overview led by myself. I'll then turn it over to Dr. Socinski to talk more about the diagnostic pathway. We'll feature Michael's story and his expert guidance from the patient lens, turn it into some resources and education, and then we'll close things out with our moderated Q&A. So starting with a little background on the Lung Association, for more than 120 years, Americans have trusted us to protect their lungs, whether it's researching treatments and cures for lung diseases, keeping kids off tobacco, including e-cigarettes, or advocating for laws that protect the air we all breathe. Our vision is a world free of lung disease. So with this, our goals are big. They are to defeat lung cancer, champion clean air for all, improve the quality of life for those living with lung disease, and to create a tobacco-free future. Each imperative we lead is constructed with the idea that achieving health equity must be the foundation of any lung association goal, objective, or strategy, and that's because when you can't breathe, nothing else matters. We've taken significant strides to defeat lung cancer and increase health equity. Our priorities for lung cancer education this year are to increase awareness of lung cancer screening availability and eligibility criteria by ensuring access to care and early diagnosis of lung cancer for high-risk patients. We also work to reduce lung cancer morbidity and mortality rates by catching lung cancer before it spreads through effective and destigmatizing lung cancer communication methods. We work to equip providers and patients with the tools, interventions, and education they need to navigate the diagnostic process with as much support and guidance as possible. And we also aim to improve health equity and lung cancer treatment outcomes for communities of color who currently are less likely to receive surgical treatment and more likely to receive no treatment. And lastly, we work to provide lung cancer survivors with the community and support that they share so that they can share their stories and serve as mentors while empowering and inspiring others. So what is lung cancer? Lung cancer is a cancer that starts in the lungs. A cancer that spreads to the lungs from other parts of the body is not technically considered lung cancer. It begins when healthy cells change or mutate, causing them to grow uncontrollably. These abnormal cells cluster together to form a tumor, destroying healthy lung tissue around them. All tumors are abnormal growths, but not all tumors are cancerous. And then we also have lung nodules, which is a smaller spot that could be benign or in the early form of becoming a tumor. It's often the first clue that leads doctors to do more testing and is often what is detected on a low-dose CT scan for lung cancer screening. It's important to note that lungs have fewer nerve endings, so many people have no noticeable symptoms of lung cancer while it's in its early stages. And in fact, most people don't develop noticeable symptoms until the cancer has spread to other organs in the body, which is when it's harder to treat and the prognosis is worse. Lung cancer is the leading cause of cancer death, surpassing breast, colon, and prostate cancers combined. About 227,000 people are diagnosed each year, and despite tremendous improvements with treatments, the 5-year survival rate is still only 28.1%. It's important to note that anyone with lungs can get lung cancer, and understanding how cancer develops helps explain why early detection through low-dose CT scanning can save lives. There are many risk factors for lung cancer. You may have heard that smoking is the #1 cause of lung cancer, and it does contribute to 80 to 90% of all lung cancer cases. Radon is the second leading cause of lung cancer, but other risk factors that may also lead to this diagnosis include exposure to hazardous chemicals such as asbestos, arsenic, petroleum products, particle pollution, genetic factors, and even secondhand smoke. Most often, lung cancer is linked to the dangerous chemicals that we breathe, but lung cancer can also happen in people with no known exposure to toxic substances, which is why awareness is critical. Lung cancer is also a journey, and it's important to ensure that patients are supported at every step. The continuum of care really focuses on prevention, detection, diagnosis, treatment, and survivorship. And it allows us to have very clear and comprehensive focus areas to ensure that patients understand early detection and timely follow-up, that early detection and timely follow-ups give you the most options, that each test or scan has a clear purpose to guide personalized decision, that treatment plans are tailored to the specific type of lung cancer and overall goals, and that there are more treatment options than ever, including clinical trials. We also emphasize supportive care so that managing symptoms, stress, quality of life is also part of treatment. And then we have survivorship, which is supported with a focus on follow-up and care to help you stay well after treatment. And we also encourage asking questions so that you may stay engaged throughout the entire journey. There are really two main types of lung cancer, small cell and non-small cell, but various subtypes exist within those types. Small cell lung cancer is almost always associated with cigarette smoking. Non-small cell lung cancer is more common and makes up about 80% of lung cancer cases. This type of cancer usually grows and spreads to other parts of the body more slowly than small cell lung cancer does. And it's important to note that lung cancer patients work with their doctor to understand exactly which type of lung cancer they have and what that means for treatment options, as some people have certain biomarkers that reveal why their cancer is growing uncontrollably. You may have heard of biomarker, molecular, or genomic testing, which is a way to get more detailed information about the makeup of the tumor. It involves testing tumor tissue for abnormalities in its DNA and levels of specific proteins of the tumor. Biomarker testing is so important because if doctors know exactly what causes the tumor to grow, a patient may be able to go on a targeted therapy that can slow tumor growth and shrink the tumor, and often comes with less side effects, time commitments, and which is better than traditional chemotherapy and radiation treatment side effects. You may have heard of lung cancer stigma, which is related to the word stigmata. It is defined as a mark or a brand of disgrace associated with a particular circumstance, quality, or person. In this case, it's a disease. Lung cancer is often stigmatized because many people mistakenly assume that it is always caused by smoking, leading to unfair blame and judgment towards those diagnosed. I want to make it clear that no one deserves lung cancer. Lung cancer can affect anyone, smokers, former smokers, and people who have never smoked. Caregivers in particular can play a key role in reducing stigma by reinforcing positive, compassionate language and advocating for their loved ones. Lung cancer survivors, it's important to know that your story matters and that you are not alone. Speaking up when you feel comfortable can help challenge misconceptions and support others. And there are support groups, counselors, and patient communities that are available to help manage the emotional impact of stigma. Research shows that stigma negatively impacts every facet of society, from the individual to the institutional. It creates feelings of shame, guilt, embarrassment, isolation, and blame for patients and their families, and undermines quality of care, access to care, quality of life, patient outcomes, research funding, and public policy. But these feelings are really not to be placed on the patient burden, since you already carry the focus should always be on support and healing. Healthcare providers are in the key position to either reinforce or reduce internalized stigma, as stigma can delay screening, diagnosis, and treatment. Encouraging open, judgment-free conversations helps people to seek care sooner. Healthcare professionals and their body language, word choice, and tone are important to consider in conversations with individuals, especially when considering tobacco cessation and/or lung cancer screening, because our research has shown that empathy reduces stigma. You've heard me mention screening a couple of times now, so before I turn it over to Dr. Socinski, I wanted to take a moment just to go over what screening actually is. There are two ways that lung cancer is detected. One is through incidental findings or on accident. An example of this can be when a nodule is found on a scan or x-ray after a work-related injury or a car accident, for example. The other way it is found is through intentionally searching for it through a lung cancer screening by way of a low-dose CT scan. What it is a low-dose computed tomography. It's a special type of imaging test that takes detailed pictures of the lungs using very low levels of radiation. It's designed to detect lung nodules or cysts, and if those findings are suspicious and further diagnostic testing is ordered, then it is a very effective way of catching lung cancer early, often before symptoms appear when treatment is most effective. What makes low-dose CT screening so valuable is that it's easy. The test is simple and non-invasive. Patients don't need to do any special preparation, which helps reduce barriers to participation. It's also safe. So low-dose CT uses, again, that small amount of radiation, which is much less than a standard CT scan, and doesn't require contrast dye. That means that it's safe for repeated use over time for those at high risk for annual scans. It's also affordable. Most major health insurance plans now cover low-dose CT screening for people who are at high risk, making it more accessible for the communities who need it most. It is quick. The entire scan takes less than 10 minutes, which makes it easy to fit into a patient's regular healthcare routine. And lastly, it's effective. Research consistently shows that low-dose CT scans can detect lung cancer at earlier stages, when treatment has the best chance of success and survival rates improve significantly. Thank you for listening to my brief presentation on lung cancer. I will now turn it over to Dr. Socinski to jump into diagnostics.
Thank you, Nicole. I'm going to take control of the slides and move on to my first slide. And this is to pick up on what Nicole was just summarizing with regard to lung cancer screening. Here are the most recent U.S. Preventative Services Task Force guidelines for the eligibility for lung cancer screening. 50 to 80 years of age, you should be asymptomatic. You should have at least a 20-pack year history of smoking. What this means, we define pack years by the number of packs smoked per day times the number of years that someone did smoke. So 1 pack a day for 20 years would be a 20-pack year history. Obviously, 2 packs a day for 30 years would be a 60-pack year history. And we know from studies done long ago that the risk of lung cancer increases with the pack year exposure, but it doesn't guarantee that you'll get lung cancer. And also the last criteria is that you are either currently smoking or have quit smoking within the last 15 years. If you fit these four criteria summarized here, then you are eligible for lung cancer screening. This, in my opinion, as a thoracic medical oncologist, is not an oncology issue. It's really a primary care issue. And we see that nationally of those patients who would be considered at high risk and might fit these four criteria, that only approximately 18% of patients are getting screened for lung cancer. So we have a lot of work to do. I would shout out to all listening today to ask your primary care doctor if you're eligible for lung cancer screening, because I think it is important. As Nicole mentioned, it saves lives, and it's important for those who are fitting these criteria. If you are screened, and you have a finding, now what? Well, the good news is that most of the findings on lung cancer screening turn out not to be lung cancer. It's only a small minority of patients that are screened and they find lung cancer. And as Nicole mentioned, it's typically found at a much earlier stage and therefore much curable. If there is a finding on the screening CT scan, the low dose CT scan with regards to its interpretation looks at what's called the lung RADs. And what this is kind of 5 subsets of 1 through 5. And what is the rating is really based on how suspicious does the nodule look or look. If it's highly suspicious for lung cancer, this might be something that would be perhaps a larger size, maybe more than a centimeter. It has what we call spiculated margins, which means it looks kind of jagged around the edge of this sort of thing. That would be something that would be highly suspicious for lung cancer, versus something that was looking at less than a centimeter, looking completely round and spherical, no uneven edges, and might even have some calcium in it. These would be considered very, very low risk for cancer. And what happens after that? Do you need another scan? Do you need another biopsy? Or do you need a biopsy? And do you need to take the next step is kind of what's assessed with that screening thing, and really based on the risk guided by the lung RADS system. As I say to my patients, the most important thing is first to know what the diagnosis is beyond a shadow of a doubt. Obviously, one has to do a biopsy to obtain tissue from whatever the abnormal finding is. Sometimes that biopsy is what we call a core biopsy, where a core of tissue is removed from the specimen. Sometimes it's what's called a fine needle aspiration, which is a needle very similar to what you would get your blood drawn with, but you kind of suck cells out of the abnormality that you see on the CT scan. The first step shown to the right here is what's it look like under the microscope, something we call histology. Nicole mentioned, the difference between small cell and non-small cell, and there are different subsets of non-small. So that's important from the medical oncologist point of view, knowing what it looks like under the microscope. It's also critical that whoever is doing the biopsy get adequate tissue for further testing. And as I say, cancer is a disease of the DNA, and it's important to interrogate the DNA of the cancer to see if it gives up any secrets. We know there are a growing number of DNA aberrations that are found in this disease that have a number of FDA-approved targeted therapies, which are for patients who have these aberrations, much more highly effective in terms of shrinking the tumor and keeping it under control compared to traditional chemotherapy or immunotherapy or radiation therapy. So comprehensive genomic testing is, in my opinion, part of the diagnosis. It's not optional or recommended. It's mandatory that it's be done. And every patient with lung cancer should ask about the multiple DNA and RNA alterations that may be present and make sure that they're either been ruled out or ruled in by comprehensive genomic testing. The second thing we need to know after the diagnosis is confirmed is what is the stage and why is that important? Staging is done by a system that we call the TN and M system. T really talks about the primary tumor. How big is it? Does it invade anything in the chest? And those are how we kind of think about the T stages. And the T stages go T1, 2, 3, 4. The second consideration is the N, which means lymph node involvement. Are there abnormal lymph nodes? Where are those abnormal lymph nodes? How big are they? These are important factors with regard to the staging. And then M stands for metastases, meaning is there any spread of the disease outside the chest or to the lung lining? And why it's important to know the stage is it determines the prognosis as well as the treatment options. And I say to all my patients, there are two things that we always have to know beyond a shadow of a doubt, and that is A, the diagnosis, and B, the stage of the patient, because that dictates treatment options. So ask your doctor about the diagnosis, and that would include the molecular testing and what the stage is. And where does my case fit into the staging of 1, 2, 3, or 4? And I would encourage every patient with lung cancer dealing with lung cancers to ask your doctor, do you know everything you need to know about my lung cancer to make the right treatment decision for me? You know, I said this of interest. I was being interviewed by a local newspaper medical reporter. We had a nice little chat during Lung Cancer Awareness Month about lung cancer. This was several years ago. And she said, as we ended the discussion, she said, what's the one thing you would want every lung cancer patient to know? And this is what I said. This is the statement I said. I would want every patient with lung cancer to say their oncologist, do you know everything you need to know about my lung cancer to make the right treatment decision for me? And she looked at me and she said, you can't say that to a doctor. I said, if you can't say that to your doctor, you should get another doctor. So the diagnosis and stage, again, gets to how we approach treatment. In early stage disease, it's important to see a surgeon, and a thoracic surgeon, not just any surgeon, a dedicated thoracic surgeon. Sometimes patients are not fit enough to do surgery, so we have what I call surgery without the incision, and that is radiation treatment. And radiation can be given in kind of standard ways, or there are now very targeted radiotherapies. SBRT stands for stereotactic body radiation. Gamma knife is a kind of a pinpoint radiation machine, if you will. It gives a very high dose of radiotherapy to a very small portion of the body, so it can be highly effective. With regard to systemic therapy, when we think the cancer has spread, or we think, even though we don't detect it, that there's a chance that the cancer has spread, then patients need systemic therapy. That could be chemotherapy, it could be immunotherapy, it could be targeted therapy, or it could be some combination of the above. Two other aspects of importance, and that is the role of palliative care. Our national guidelines say that palliative care consultations should occur around the time of the diagnosis. Many people interpret palliative care as end-of-life care. That is not. That is hospice care. We're talking about palliative care. Palliative care are expert doctors that are trained in symptom management and management of the disease, along with the oncologist. And there was a famous study done years ago suggesting that the integration of palliative care into the treatment plan for lung cancer patients actually can increase overall survival of these patients, of lung cancer patients. And then lastly, nurse navigation. I have 2 or 3 wonderful nurse navigators who take care of the patients, are very versed in lung cancer, will help them explain things, are available to help them navigate what often can be a relatively fragmented and complicated medical care system. It just takes the pressure off the patient when they have kind of like a guardian angel looking over them and getting them to their imaging, their blood tests, biopsies or surgery or any of the above. Our navigators are actually quite important in that regard. You know, I like to say to my patients, my job is to get you into the right treatment bucket. We have lots of things, as I've mentioned, surgery, radiation, chemotherapy, immunotherapy, targeted therapy. I've always said that the thing that you do first for a patient makes the most impact, and therefore you better get the patient in the right bucket of treatment right from the get-go, because sometimes you can't reverse that decision. And as I like to say, my job really is to get the right treatment to the right patient at the right time. And again, what you do first, I think, is the most impactful. And so I've always said you better get it right the first time. Now, I've mentioned the molecular testing. We can do that testing on a tissue biopsy, like I've mentioned before. We also know that tumors will shed their DNA into the blood. So blood testing is also an integral part, and I think really has been, in many cases, a game changer. Again, getting back to the importance of comprehensive biomarker testing. What the biomarker is something in the tumor that's telling you when it's present that the use of a targeted therapy is indicated. And again, as I've mentioned, these therapies are much more effective than chemotherapy or immunotherapy. We can do comprehensive biomarker testing either in the blood or the tissue. And it turns out that in my practice, most of the time I do both because I believe that they are complementary. Sometimes we find things in blood we don't find in tissue. Sometimes we find things in tissue we don't find in blood. And therefore, the important thing is that you find something. And so these can be complementary. And I use both of them in the vast majority of patients because I think the most important thing is to find something if it's there. There are other diagnostic procedures that we typically do, and I've mentioned there the PET scan as well as MRI. Those two tests are how we complete our staging sorts of things. Again, as I've said, it's important to get both that diagnosis and stage correct. It does take time to get these scans started. Oftentimes, frustrating not only for the patient, but for me personally is the pre-authorization that's required for these sorts of things. We struggle through that. And what one should expect from your oncologist during this staging process is to relay the importance of why tests are being done, the status of these tests, and ultimately, once they're completed, having a nice discussion about the diagnosis in the stage. Now, almost everything I do in the treatment of lung cancer is based on clinical trials that were done in the past. Clinical trials are the engine of progress in cancer medicine. When to consider a clinical trial? Every time you have a diagnosis of lung cancer. I believe that clinical trials represent a standard of care. They're not always the standard of care. But as a patient, one should ask your doctor, is there a clinical trial that I might be eligible or that might be pertinent to me? There are all different types of clinical trials. Some involve first-in-human experiences. Some involve comparing a new treatment with a standard treatment. So there's a big spectrum of what these trials are like. I tell my patients that there, almost in all situations, there's an accepted standard of care. And I would never recommend a clinical trial to a patient that I thought did not meet the standard of care or offered a chance of a better outcome than what the standard of care is. So it's important that patients partner with their physicians. For this, you can see at the bottom there are some reasons why you should participate or consider participating in a clinical trial. There are situations where there are brand new therapies that may be important for your type of cancer. There may be situations where the standard treatments are effective, but maybe we think we can do better, or there may be issues with side effects. Um, uh, and of course, obviously, we have to make sure that patients are comfortable, understand what the clinical trial is about, understand what phase of clinical trial it is and why it's important at their point in the disease. So please ask your oncologist or treatment center if trials are available for you at that particular time. So a little video on shared decision making. So my final recommendations are somewhat summarized here. Um, we've talked about the importance of diagnosis and stage. I would encourage you, in many of my patients will have access to their reports before we've had a chance to meet. My experience has been it's pretty complicated medical vocabulary, the description of a CT scan or a PET scan or a brain MRI or these sorts of things. There are lots of noise in many of them. I've been doing this for 35 years, so I feel pretty confident about sorting out the noise. But patients do, and I worry about the level of anxiety um, that it provokes in patients. So I would encourage you to read your reports, but why don't you wait to see the doctor first so he can explain the significance uh, um, of the report. Second opinions, I think, are very helpful. I welcome them. I think that the more eyes you have looking at a particular case, the better it may be. Sometimes I will send patients for a second opinion. Sometimes patients request them. I never think it's a bad idea. It's not necessary in every case. There are many cases that we feel are, from our perspective, relatively straightforward, and we know what the second opinion would be. But it's important, particularly if the patient desires another opinion. Multidisciplinary care, your care team should be a mix of thoracic surgeons, medical oncologists, radiation oncologists, interventional pulmonologists, interventional radiologists. The pathologists, the molecular pathologists are part of the team. Thoracic radiologists are part of the team. We get this entire group together once a week to discuss difficult cases. So that multidisciplinary care is important. And as you saw in the video, shared and informed decision making. I say to my patients, uh, this is a partnership between patient and physician, and they need to look at it as a partnership. And I think that puts people at ease because there's uh, sometimes a little bit of intimidation about questioning a physician. You shouldn't be intimidated about questioning us. That we're in this together. It's shared decision making, and you want to just make sure that everything is being addressed so that at the end of the day, there's excellence in the delivery of care to the patient, and the patient feels confident in the decisions that are made. And oftentimes, patients will say to me, you're the expert. You do this for a living. What would you do? And I tell them exactly what I would do. And I think that's what they deserve. But I think it's important to kind of feel comfortable and view it as a partnership that you're trying to make these decisions in. So I think with that, Nicole, I will turn it back to you.
Great. Thank you so much, Dr. Socinski. We will see you soon for questions and answers. Next up, we have Michael Hu to present on his story and journey with lung cancer. Michael?
Everyone, yeah, thanks for joining for this. So I'm going to share my story, and actually, since Garden is one of the co-sponsors or the sponsors for today's talk, um, they actually did a story, did a video story for me. So I thought it would be great to leverage that for part of today. So I will play that and then kind of bridge the gap from that video to where we are now, and then continue on from there. Um, Here we go. jumped ahead for some reason. So yeah, thanks for watching my story. I kind of find it funny that at the end they say unscripted, talking about unscripted moments, but they show a picture of a very scripted hug. Um, anyway, so that video was done last year, and unfortunately since then, it did mention that I had progressed once. Unfortunately, I've progressed several times since then. And so just to catch you guys up really quick, right? So I was, diagnosed 2022, got genomic testing, got on a targeted therapy. Um, I progressed in 2023, did genomic testing again, switched to a different targeted therapy. Progressed the following year, 2024, got genomic testing again. Based on that, switched to a third targeted therapy. And then unfortunately, earlier this year, I progressed a fourth time. We did genomic testing as well, but unfortunately there wasn't a known targeted therapy that we could leverage against that, so we added chemotherapy on top of my targeted therapy. I progressed in the brain and then switched target therapy again. So yeah, it's been quite a journey, and I definitely have a lot of experience with navigating through progression. However, even like a like kind of a depiction of my cancer journey this way seems to be still a little oversimplified for what a lot of us as cancer patients seem to experience. So I just wanted to delve into a little bit more detail of what my overall cancer journey has been like, just to give more of a realistic view of all the different twists and turns and considerations that can happen. So, um, one second. None of my animations are working, but I'll just walk through this. So so when I was diagnosed in 2022, as I mentioned, um, got on a targeted therapy. I also ended up having radiation to my spine for 10 days. A year later, after the testing and switching to a different targeted therapy, I also ended up getting additional radiation in the liver through radioactive beads to try to eliminate a residual spot there that the new targeted therapy wasn't able to fully resolve. Shortly, about a year after starting that therapy, I did show some additional progression, but we want to try to extend the time that I had on this current therapy. So we monitored it for a little while, confirmed that it was truly a metastasis, and then we attempted to do a liver ablation using microwave ablation to try to uh, kill that one single spot, and hopefully I could keep going. Um, at the same time, we did do additional genomic testing to find out what that mutation was. We did find out it was a double mutation. However, in spite of the microwave ablation, I did end up progressing again. New spots had formed outside of where we had ablated. And after deliberating with the doctors, getting several second opinions, doing my own personal research, and then working together with all of them, we decided to pivot to a different targeted therapy. Bit of an unconventional path, but it definitely was a great example of shared treatment, shared decision making amongst me, my oncologist, and second opinion doctors. Unfortunately, I did progress a fourth time, as mentioned. I was able to get data from the genomic testing and try to zap that new spot again. Like, it seems to be the liver where I had the majority of most of my issues. We actually, for this one, there were several spots, but there was one larger spot that we had decided we wanted to try to get rid of that so we could give myself more time if needed in case one of the treatments I took ended up not working, right? I was trying to hedge my bets and we had to make some careful decisions that way. So we zapped that one spot. There were several residual spots left, and we decided that adding chemotherapy to my existing targeted therapy was the route we should go. A couple weeks later, scans to check on how things going showed that I had progressed in my brain, and so we pivoted back to a previous TKI that has greater brain penetrance. And so that's the current regimen that I'm on now, chemotherapy plus this lorlatinib TKI. The last scans do show that it appears to be shrinking what's in the brain and holding it stable, as well as in the liver. However, I do have a suspicious new spot that we're monitoring, and it's likely that I'll have to pivot therapies again sometime in the next several months. One thing that Dr. Socinski mentioned is that we heavily rely on genomic testing, and there's a few other things that they did find. One of them was a MTAP deletion, and even though that's not an actionable mutation now, there are several clinical trials currently, as well as a couple about to start of drugs that are very promising drugs targeting this. So that may be a new modality that I can, a new treatment modality that I can leverage in the future. Oh, now the animation's working. And I also have a TP53 mutation. That's not really targetable, but it does tend to have a greater association with poorer prognosis. So while I can't really do much with that, it does make me ensure that I'm more vigilant about keeping up with my scans and making sure we're monitoring things as close as we can, because I do have that mutation. So that's an overview of my journey. As you can see, navigating through cancer can be very complicated, very complex, and through it all, you definitely need a lot of strong support, both from peers as well as from doctors, to really help make sure you make the right decisions at all the key points, and also be able to maintain your quality of life as best as you can throughout. As you can imagine, the emotional journey is quite daunting, especially during your lung cancer diagnosis. Waiting was definitely the hardest part, because unknowns are terrifying. The first few nights in the hospital, where we were just unsure what kind of cancer I had, and we're waiting for tests, those were definitely the darkest nights for me, where I remember just crying out in the middle of the night, bawling, thinking about all those scary thoughts of my family losing me, and just coming face to face with the fact that I was probably going to die far sooner than I wanted to. And the grief is real, even though death hadn't happened yet. It feels like you've lost everything. Your world falls apart. And in the midst of dealing with all of that, you're also getting information overload from all this information your oncologist is telling you, and any other information that you're trying to find to be able to help you navigate through this new information that you have cancer, right? And it's definitely realized that one thing I definitely realized is I couldn't do this alone. And I'm glad I didn't have to. My wife was critical in helping me to find support and other people, other support resources, and other patients like myself that I could connect to and learn from during this early period. So in terms of support, I do find that there's like 4 key areas of support that you need to find people to help you with, right? It's helpful to find both peer and professional support in each of these areas. For emotional support, of course, you have your friends, your families, and I definitely recommend looking for patient support groups. There's no one else who can understand what you're going through than people who are going through what you have. And so for me, that was one of the most helpful areas, especially right after diagnosis, as well as ongoing treatment, figuring out how to navigate through some of the different side effects and other things that can crop up. I also highly recommend and emphasize you need to take care of yourself. So make sure you do self-care. Professionally wise, of course, you rely on your care team. And I highly recommend a mental health therapist. I started seeing one, and it's been like she's been a baseline of support for me ever since. Physically, staying in some type of physical shape also helps. Take walks with a friend, with your care partner. Professionally, seeing a nutritionist, seeing what your oncologist office has there, and consulting with them can definitely help, especially if there's any dietary concerns that you have when starting treatment, and if you're looking to see if there's anything you can eat to help with your health. And don't excuse me. I definitely recommend don't neglect your routine visits. See your routine PCP. Go see your dentist. Get your vision done. These things are all still important. Just because you have cancer doesn't mean that that your life is over in other areas. And the hope is that you're going to live longer. So you want to make sure you take care of all the rest of your body as well. Financially, you definitely want to probably check in with a financial planner. I did. It was very helpful to make sure that I had all the important things taken care of, and to take action on things that I needed to get your estate plan taken care of. There's a great resources on Triage Cancer. I would highly recommend that site. In terms of peers, a lot of your friends and family, they'll want to help you. And getting meals delivered to you is super helpful. Some of them may want to do like a GoFundMe, and sometimes like you may feel a little bit awkward about taking money or things, but oftentimes, giving your friends an opportunity to be able to help out in some way is a great way to connect with them. It's a great way for them to feel that they're making a difference in your life, and you can't help but also benefit from it as well. Informational support. When you get cancer, you definitely want to learn about your cancer so you can really navigate the best you can, because no one's going to be a better advocate for yourself than you. And so you want to equip yourself to do so. And again, I highlight patient support communities are critical. They oftentimes have some of the best resources, and can provide what you need just technically, as well as just from emotionally and emotionally, and just as commiserate as people who are going through the same experience. Of course, you want to depend on your doctors, and also some trusted cancer sites such as American Lung Association, American Cancer Association, et cetera, et cetera. Right. Where you start matters. I remember my sister told me from her experience being in the pharmaceutical industry that the treatment that you start on matters, because oftentimes what you start on can determine the trajectory of your journey. And as Dr. Socinski mentioned, I do agree and want to highlight that it is worth waiting for the best data you can to determine the right treatment for you, but definitely don't wait too long. You don't want your cancer to grow, to get to a point where it may start impacting your body in a way that you may not be as receptive for the best treatment that you may need to go on. So finding that timing is key, and working with your care team to make sure that you're threading that needle correctly is definitely critical. You also do want to make sure that you have access to the right care team, so that you have the right people to help you make those decisions. I just want to highlight what Dr. Socinski mentioned. If you ask your doctor, or if they know everything that do they know everything that they need to know to help you the best, and the answer is shaky on that, you want to find somebody else. Don't play games or take chances with your treatment, especially in the beginning. Second opinions, I definitely want to highlight, are key. You want to find the right people. I know for me, when I progressed the second time, my doctor, and as well as one of my specialists, was directing me towards this clinical trial. But I got a third opinion, actually, from a different doctor who was more familiar with that drug. And she had some more insight that that drug may actually not be as beneficial for me based on some of the early data and pointing me in the direction of a different trial. And that was pivotal for me because I was going to go on a drug potentially that might not have worked as well, and I was able to be redirected to something that would work better. All right. The patient-provider relationship. Oftentimes I get asked, what do I do? How often do I see people? How often do I get scans? When I'm stable, I get scanned every 3 months. I do have a specialist at Hopkins, and I do see my primary oncologist at Penn. So I send my scans to both of them, and I get them read from both doctors. You don't have to, but that's just something I do. Clinical visits, every 3 months after scans. I do see my mental health therapist biweekly. It's part of my regular routine now. And palliative care. Highly recommend seeing palliative care because they'll give you the time and expertise needed to help address any issue that you're having during treatment at any point during your treatment journey. And and they were able to get me onto some of the right medications in the more timely manner and more efficient manner than my general oncologist office was able to. PCP, as I mentioned as well. When you progress, this is what I do. I immediately want to find out what it is, and if my doctor doesn't request it or get on it, I initiate asking for tissue and liquid biopsies. I want both. I want data from both because I just want any data at all. Second opinions, for me, I go up to Boston to get additional opinions from either Mass General or Dana-Farber or both. And then for scans, it's up to the doctors, but you start getting scans more often depending on what you're trying to look for. And of course, you get additional reads of your scan reports from the second opinion doctors you see. And you oftentimes see your oncologist a lot more frequently. So that's a bit of my whole cancer appointment routine. As mentioned, the your care team will consist of a lot of different doctors. Mine consist of a general oncologist and a specialist in my cancer, ALK. I also have an interventional radiologist I see regularly, as well as a neuro-radio-oncologist for my brain metastasis, as well as a regular palliative care physician and my therapist. Everyone's going to have different people on their team depending on what they need, but I definitely recommend beyond your core oncology team that you definitely also onboard a palliative care and a mental health therapist if you haven't already. So I call my oncologist. He's like my quarterback. The patient-provider relationship is one of the most important relationships that you're probably going to develop during your cancer journey. For me, just an example, right? When I was getting that second opinion up in Boston, he was so good at being proactive in reaching out to first my specialist down at Johns Hopkins, syncing up with him, and then calling up to Boston, knowing that I had an appointment up there the following week, coordinating with her, making sure that she had all the information that she needed that wasn't in all the doctor's notes. And by the time I ended up getting to her office, she told me, "Hey, Mike, I feel like I already know you because of how much I've already interacted with my other oncologists." And so, even though my oncologist, he's not one of the more well-known ones, I stuck with him because of how well he cares for me, and how much he had my back, and was able to coordinate my care. He's also really great at this mutual decision making. And I feel that that's definitely very key. In the beginning, you there's maybe less for you to contribute during your diagnosis because it's new. You don't know as much, and so you really need to lean on your oncologist during diagnosis. But as you mature in your journey and grow, you really become and want to become, if this is not the dynamic on your care team, you want to become more of almost like an equal partner in contributing to what's being considered for your treatment journey. My oncologist always makes recommendations. He always listens to things that I say, like, I have questions. I saw this study, et cetera, et cetera. But he always takes that in consideration, answers my questions, but he always says, but the decision's always up to you, Mike. This is what I think. They definitely should be someone who makes you feel seen, heard, and keep you informed. And over time, I've heard from other patients as well, they really become a close relationship. Maybe one of the closest people in your life after you get diagnosed with cancer. All right. In terms of managing progression, and I've progressed like at least 4 times now, right? So it always feels like deja vu. I describe it as a roller coaster. It's a roller coaster ride, but it's one that you've been on before, because the things that you experience during diagnosis, you oftentimes will feel and go through again. Yeah, same things. You need to find the data. You need to get your testing, find the data, consult with people, make decisions, get support, et cetera, et cetera. A lot of times it's rinse and repeat, and you take the learnings from last time and you try to get better and more efficient in helping to get to the right treatment decision. Hopefully, you don't have to get too good at it. Hopefully, you're not progressing that frequently. But yeah, you can leverage your past experience even during diagnosis to help you when you progress. You've heard me say this, and I just want to overemphasize this. You have permission for self-care. If not, give yourself permission. Give yourself the time that you need to take to do what helps to refresh you, especially during these times. It's emotionally and mentally hard when you find out that there's new growth. You need to take extra good care of yourself during those times. As I mentioned, you want to make sure you get that testing done. So get those biopsies scheduled ASAP and line up a second opinion. For me, my practice is every time I progress, I get a second opinion, and it's not that I'm trying to, but it seems like I accrue a new second opinion doctor every time I progress. I'm not saying that's what you should do, but I figure for me, especially since I'm getting double mutations and mutations where there's not that much data, it gets more complex, and the more experts I have that can help weigh in on something that is harder to determine a direction, the more confident I feel on the decision that we can make together. And sometimes I hear concerns about, will my insurance cover these additional biopsies, especially the liquid biopsies? I want to highlight that oftentimes these liquid biopsy companies, such as Guard, are very good at making sure that they minimize or eliminate or minimize financial burden to the patients. So you don't have to worry whether or not you can get this test. They reached out to me when I was first diagnosed and insured, and their financial team, the billing guy, was like one of the nicest guys I talked to in the company, who ensured that I got enrolled in their financial aid, and then told me that the maximum amount I would ever pay out of pocket would be $25 if I saw a bill. Since then, I think I've only had one of my liquid biopsy tests approved by my insurance, even though I think there's some ongoing contesting there, but I've never seen a bill. And I'm really thankful for companies like Guard and other testing companies for their patient-centered practices in terms of making sure that patients get access to the testing that they need. When you get progression, also, there's a few things that I recommend asking. Check with them. Ask them what does this mean, right? Just because you have a spot show up doesn't mean it's the end of the world. Maybe it's not as bad as it looks. Maybe it's something else completely differently. Maybe there's different approaches they can take, and you don't have to, it's not a fire drill, right? And your oncologist will know the landscape of where you are and what it is and how you to best react. Definitely ask, what other tests do I need? Yeah, and based on what we know, are there any specific treatments or trials that we should be considering at this point? Scanxiety is a real thing. There's even graphics online with all these different, peer-reviewed definitions. What are things that I can recommend doing with anxiety? Well, there's this cancer doctor, Dr. Kamich. It's pretty well known in the lung cancer space. He actually became a lung cancer patient himself, and he encourages something called the 90-day challenge, which is 90 days is the amount of days usually between maintenance monitoring scans. So, in between scans, redirect some of that anxiety to do something, however small or big, whether it's to read a book or go on a trip or just initiate a new hobby. That kind of goes together with find a healthy distraction, right? For me, my main strategy is to find something to look forward to. I tend to schedule a trip or a family dinner after my scans, because regardless if the scan is good or bad, I want to have something to look forward to afterwards, to be able to spend time with people I love and do something I love. And if you need extra support, there's nothing better than commiserating with the patient community who also needs support. Reach out to them, post on the Facebook group, hey, I'm getting scans next week, wish me luck. You will get lots of well wishes, and it definitely makes a difference. Mindfulness and self-care. I'm not going to repeat self-care because I already have. Mindfulness is actually has been very helpful for me. Doing things like the self-guided meditations on the Calm app really help to reduce anxiety during times that I'm feeling like it's just really hard to control. All right, I know I'm getting a little tight on time. Oh, that's it. So that's my story and some of my recommendations. And Nicole, I'll hand it back to you.
Awesome, thank you. I'm going starting with patient education. Lung cancer survivors. This is a nice segue off of your last slide, Michael. Support communities are imperative to promoting inclusion and a sense of community, and really work to improve quality of life as patients and caregivers navigate lung cancer. Some of the American Lung Association resources include online support communities and support groups. We also offer a one-on-one mentorship program with Immerman's Angels. We have our lung helpline, which I'll talk more about on the next slide, and you can always find up-to-date information on lung cancer on lung.org/lung cancer. Dr. Socinski did a great job of mentioning the nurse navigators. The American Lung Association also utilizes and relies on our lung health navigators, or LHNs, to improve access to social services and adherence to lung cancer screenings by providing free individualized support to those at high risk for lung cancer through working to determine eligibility for a low-dose CT scan by using our Save by the Scan program. They also work to support in locating a screening center, scheduling and obtaining an order for a low-dose CT while providing follow-ups. And when funding is available, they help to pay for transportation and outstanding balances for low-dose CT scans for those who are uninsured, underinsured, or have a high deductible. And the states where that is currently offered, that patient assistance is currently offered, are Hawaii, Illinois, and Louisiana. They also work to facilitate referrals to state quit lines and lung association cessation programs. Referrals come from partnering health systems and organizations, as well as calls directly from high-risk individuals that see our marketing and awareness campaigns across our active markets. How to connect, you'll find several ways to connect, whether that's by phone, email, or web page navigation. So the communication comes in a variety of options. And some things to expect when someone does call or contact the lung health navigator are a one-on-one assessment. And that can be for a variety of lung diseases, not just lung cancer. We also cover COPD, asthma, and pulmonary fibrosis. These call options are available based on the assessment, but sometimes that can be 3 to 5 scheduled calls of 15-minute increments. We also cover education in the form of booklets, one-pagers, resources. This can include things like action plans, conversation guides, demonstration videos, and then, of course, all of our patient stories, animations like the one we saw previously on shared decision making, anything that really helps round out education on a particular topic of interest. We really work hard to pull all of our resources to these navigators so that they have everything at their fingertips and can distribute it on an as needed basis. They also provide evaluation, including 1 month and 3 month follow-up assessments and ongoing support as needed. So if you have any interest in reaching out, please call 844-ALA-LUNG. On this screen, you'll find a QR code and some screenshots of our lung cancer screening resources. These all come from feedback from our patient populations and our partners on what they'd like to see and add to their outreach efforts. We've created various resources to further raise awareness, reduce stigma, and help the general population better understand our lung cancer screening programs, resources, and the patient individual risk level. This month, we released our 8th edition of the State of Lung Cancer Report, which shows the toll of lung cancer and how that varies by state. We work to examine the rate of new lung cancer cases, survival, early diagnosis, surgical treatment, lack of treatment, screening those at high risk for lung cancer, and insurance coverage of comprehensive biomarker testing. So we really do a very in-depth data report on all of those topics, and we look at low screening rates and states that must do more to protect their residents from lung cancer. The report also includes data on racial and ethnic disparities for the above measures where available, showing that people of color who are diagnosed with lung cancer face the worst outcomes than their white counterparts. The report also provides policymakers, researchers, healthcare providers, and anyone committed to ending lung cancer with a foundation for identifying where their state can best focus its resources to decrease the burden of lung cancer. It works to empower the public with information they can leverage to start the local change we need to see, which in turn can lead to data-supported policy change and both support the Lung Association's comprehensive approach to lung cancer and advance its strategic imperative to defeat it. Visit lung.org/SOLC to learn more about lung cancer in your state and take action to join us in the fight to defeat lung cancer. Next up, we've got Lung Cancer Basics. This is our free online learning module designed to lay the foundation and I think I dropped for a second, including supplemental videos, resources, and materials to aid in acknowledging and reducing stigma, understanding why lung cancer procedures and treatment options are important, describe what lung cancer is and the different types of them, and how lung cancer can spread in the body. And the program is really ideal for those at high risk for developing lung cancer, as well as patients and caregivers, health professionals, and community-based organization staff. CMEs are available for this, and that's something that we just added this past month. Next, we have our monthly patient and caregiver connections to learn from our expert lung health navigators as they share information on a specific topic and connect with others who share similar experiences. These are offered on our patient and caregiver network. So if you, we'll send a follow-up email that has a link to this, but it's the lung cancer one is the first Tuesday of every month. And it's on a specific topic with our lung health navigator. So you get one-on-one time with them in a group setting where you get to learn about a particular lung cancer topic. And it's very informative because you do have, again, that direct access to the lung health navigator, who, as Dr. Socinski said, can be like a guardian angel during the lung cancer journey. Since it's open enrollment season, I wanted to take a moment to talk a little bit about health insurance via the marketplace. Jeff on this slide was one of our Lung Force heroes in 2025. He has lung cancer and currently gets his health insurance through the marketplace in Massachusetts. This health plan that he has covers his medication, which costs $26,000 a month and keeps him alive. We do have his story on lung.org. This past month, he joined Senator Markley in Massachusetts to talk about the importance of extending the enhanced tax credits. It's important for everyone, but especially lung cancer patients, to have the quality health insurance that they need. Open enrollment is when people can choose a health plan for the next year, and this year's marketplace open enrollment runs November 1st through January 15th in most states. The Lung Association has a ton of information on enrolling in affordable care. In the affordable care marketplace health insurance plans at lung.org/open enrollment. We work to keep it up to date as federal policies change and marketplace coverage is impacted. Health insurance premiums have gone up because Congress has not extended extra financial assistance, also known as premium tax credits, for 2026. Despite this, most people will get some financial assistance. So shopping around on healthcare.gov may yield a different plan that is less expensive, but please beware of enrolling in a catastrophic plan, as it does not provide comprehensive coverage that lung cancer patients and most people need. And finally on this, we again have a lot of resources in English and Spanish on lung.org. We'll continue to update information as the tax credits change. And there's also our local lung health navigators in every state that can help people with specific questions. And you can encourage patients to join by our Ask the Expert session on Inspire about ACA open enrollment. If you have any questions about the Lung Association's open enrollment materials, please contact your local Lung Association office, or hopefully by now you know how to get a hold of our lung cancer education team email. Lastly, you can raise your voice right now on urgent issues in lung health. Our online action network provides alerts on petitions to make it easy to advocate and protect our lungs and save lives. So you can, if you'd like to join that, you can visit lung.org/action or utilize the QR code on the screen. Before we jump into Q&A, I wanted to provide a formal thanks to our sponsor for this presentation, Guardant. Thank you so much for your generous support and dedicated partnership that has allowed us to reach today's new audience and to build awareness and resources about lung cancer diagnostics, lung cancer staging, and treatment options for lung cancer patients and caregivers. We have had a tremendous amount of information shared today. And so I want to turn it over to Dr. Mark Socinski and Michael Hu to answer some of the questions that we got. There were about 17 questions yielded through the registration process. So we will cover some of those today. And then we have some that have come in the Q&A as well. I will be moderating this. So before we jump into that, I just wanted to note that if anyone couldn't see the animation that was shared today or Michael's story, we will be sharing those links in a follow-up email. And if you would like to view Michael's story, the link for that is in the Q&A box at this time. So if there was any type of technical difficulty with that, please find those links in the Q&A box, and we'll also be sure to cover the send out of those after. Starting with a question for Dr. Socinski, what is the size of lung nodules that are suspicious?
Well, size is only one part of the story. I mentioned before when we talked about screening, is it a spherical, like smooth edges? Does it have calcium in it? Is it spiculated, where you might be more suspicious of cancer? So we generally use the 1 centimeter rule. At least that's the rule that I use. If it's above a centimeter, I get more concerned. If it's below, and depending on some of these other features, size is just not the only criteria. So you really have to let your expert radiologist look at it and kind of get back to answering the questions about how suspicious is it in a setting. And of course, that depends on some clinical features, smoking history, age, these sorts of things. So size is just one part of the equation.
Thank you. Next, we have a question from Michael. You covered and mentioned second opinion several times, but could you share a little bit about when would be a definitive moment in time to get a second opinion?
So I would say, I mean, it's not necessarily like a, cut and dry when to get it. Generally, I would say if there's a key question that you need to have answered and you need and you want to make sure that you have some validation from another specialist, I would say that's when you would get it. For example, um, when I progressed, right, and it was just uncertain. I had exhausted my first line and my second line. We weren't sure what to go to next. So there was a key question of, when we're beyond the standard of care, where should we go, right? And so I wanted to make sure I got a second opinion, especially for that question. So I had at least, um, you know, two expert opinions to consider. When I got diagnosed, I actually did not get a second opinion, and I don't really feel like I needed to at the time because my case was pretty cut and dry. All right, like I was diagnosed with ALK. Um, if and there was a specific medication that was the preferred first line, and that's what I was put on. Um, and it seemed that was very tolerable and would be pretty effective. If I had more questions and I was questioning like, well, if it was something that had higher adverse effects or maybe less efficacy, I would maybe be like, are you sure this is the right one? If there's additional questions, I would seek additional opinions. But it also depends on what question, how critical the question you're trying to ask. So I hope that helps.
Thank you. This next question is for Dr. Socinski. This person writes, I'm stage 4 with multiple meds, immediate treatment while waiting for gene sequencing results. Can you speak to the FLORA-2 study versus the Tagrisso monotherapy?
Yeah, FLORA-2 is an important trial. So, as we've said several times, it's important to get all the information so that you make the right decision initially for the patient. Because again, I think the thing that you do first is the most critical and has the biggest chance of having the biggest impact. Oftentimes, I always say lung cancer is rarely a medical emergency. It's almost always an emotional emergency. So you have to, talk with patients about the importance of comprehensive genomic testing. That can take a couple of weeks before you get all the information. And you just kind of say, well, my job, again, is to get the right treatment to the right patient at the right time. Now, having said that, there are patients who are highly symptomatic who really do need to start treatment. In that case, we would generally recommend that patients get one cycle of chemotherapy. A cycle is typically 3 weeks long, so it kind of buys you 3 weeks. By that time, you should have the molecular testing done. And chemotherapy is still a very good treatment for many cancers, and it may help with the symptoms and reduce the extent of the tumor significantly. Most of the benefit of chemotherapy happens in the first couple of cycles that you get. FLORA-2 asked a question with regard to osimertinib or Tagrisso. FLORA, the original trial, compared osimertinib, which is what we call a third generation tyrosine kinase inhibitor, to the two first generation. I won't go into details of the differences between the generations, but the third generation drug is just a better drug. And in FLORA, they saw that osimertinib was better than the first generation drug. So that kind of became the standard of care 5+ years ago. At about the same time that osimertinib was emerging as the standard treatment for this as a once-a-day pill, there was a trial done in Japan and a trial done in India where they added chemotherapy to the first generation drugs. And those trials were actually both positive for overall survival. So patients lived longer when they got chemotherapy with the first generation TKIs. So it begged the question, well, maybe we should give chemotherapy with osimertinib and see what happens. And that's exactly what FLAURA2 was. And just a month or so ago, we saw the final overall survival analysis suggesting that the addition of chemotherapy to osimertinib actually yields better outcomes with regard to survival. So that's kind of what FLAURA2 told us. Now, does everyone need chemotherapy? No, I still think there are patients that can do quite well with just single agent monotherapy with osimertinib. But I do think there are a number of clinical situations where more intensive therapy, in this case, with the FLAURA2 regimen. There's also a regimen called the Mariposa regimen, which is also a more aggressive regimen. So we have lots of or several different options in the first treatment of patients with EGFR mutations, which is what all of this is all about. So I hope that addresses your question.
Absolutely. Thank you. This next question is for Michael. What prompted you to start sharing your story, and what advice do you have for someone who is thinking about sharing theirs?
What prompted me was someone asked me if I'd be willing to share for, I think it was the American Cancer Society. They were just collecting stories. So for me, it was, I saw it was offered an opportunity, and I, I wanted to, it kind of sounds a little funny, but like, I want to do something with my cancer besides just try to like live through it. And even though I wasn't actively looking for a way to leverage my story to help others, when an opportunity came by, I definitely took it. Now, if you are interested in wanting to share your story, just reach out to any of these groups. I found out that they are always looking for people to share their story. And if you're a little bit shy, you just do like maybe like an online journal. Some people do caring bridges to share their story and their journey with their family and friends. And sometimes that's a good way to get started in a written form. But yeah, I mean, all these groups are looking for people like myself or you as a patient to share their experiences, because that diversity of perspectives always is beneficial in helping others.
Dr. Socinski, what should be the next step after a lung nodule has been seen on a CT scan of the abdomen? Is it straight to biopsy? Do we do another scan in a couple of months? What does that look like?
And this is not an uncommon situation. I have several patients that have shown up in the emergency room with abdominal pain. They get an abdominal CT scan, and of course, an abdominal CT scan, to visualize all the liver, you see about the bottom third of the lungs. So we picked up a couple nodules that way. The first thing I would do is to do a dedicated chest CT to see, is this a solitary nodule? Are there other nodules? Are there other findings in the chest that you need to take into consideration? And then it gets back to what I said before about the nodule. What are the characteristics of the nodule? Does it look benign? Are there old films? Did the patient have a CT scan for some reason 4 years ago, and was the nodule there at that time? Most patients don't have a CT from 4 years ago, but you'd be surprised, many cases they do. And so you can go back and compare it. But you got to look at the nodules. You got to make sure there are no other findings. Sometimes the right answer is to do a short follow-up CT scan to see if it's changing. That would be 2 or 3 months later. Sometimes if the nodule looks very suspicious, and there's clinical features such as a strong smoking history, might be more concerned about it. So it might go immediately to biopsy. So there are lots of variables here that would determine what one would do.
Thank you. This next question, Dr. Socinski, covers diagnostic tests after progression. Should they be redone? This person reports having ret non-small cell lung cancer.
Yeah, no, Michael's case is take this as a positive thing, Michael. It's a beautiful case where retesting at the time of progression was informative. It helped make decisions, and I think good decisions for the patient. So I always say, it's important to figure out why your initial treatment, and in this case, it was a targeted therapy. What's different about the cancer now, where the treatment is no longer working? And if there is a difference that you find, is there something differently you can do about it? And I think sometimes these second biopsies, whether they're plasma, liquid biopsies, or whether they're tissue biopsies, they can be quite informative, and it's important to know that information. The only other comment I'll make about this is occasionally, and this is relatively rare to uncommon, occasionally there can be what we call histologic transformation, that the cancer that is typically looking adenocarcinoma, which most of these cancers are, transforms into a more aggressive type of cancer, like small cell lung cancer, or we've had a couple cases of sarcomatoid carcinomas. You should be suspicious if the clinical behavior is such that it seems to be stepping up the level of aggressiveness of the cancer, in which case a liquid biopsy is really not going to be that helpful. It would really be a tissue-based biopsy to help look at this issue of histologic transformation. Did the cancer change? So those would be my comments. But it's very important to reassess at the time of progression to figure out why what was working is no longer working. And
Thank
what
you
to
so
do,
much.
and what to do next.
Got it. Thank you. Well, we are right at time. So if your question has not been answered, we will follow up to you directly with a response to your question, and we will get those answers to you within the week. We will also provide a follow-up email after this presentation in the next day or so, with plenty of these resources on education, tools, and patient stories and videos as well. Thank you so much for your attendance today and for tuning in. This concludes our webinar. Take care, everyone.
Thank you.